Hello and good morning or good afternoon. Welcome to the ERN-RITA webinar. I'm so happy, and my name is Marco Gattorno, and today, together with my co-moderator, Uziel, my good friend, we are a great honor to have the moderation for this exciting webinar. I ask Professor Uziel to introduce our two distinguished speakers. Thank you very much.
Thank you, Marco. So both speakers today, I can call them the queens of autoinflammatory diseases. Both had very influenced and internationally, both were presidents of the International Society of Autoinflammatory Disease. Both are excellent physicians and researchers and well known in every field in rheumatology, but mainly in the autoinflammatory area. Both of them had hundreds of publications. So I think Helen is the first. So welcome, Helen, and later on Seza will join.
So thank you very much. I'm delighted to be speaking. I'm very, very pleased to be co-speaking with Seza. It's always very nice to do this with old friends. So we were asked to talk about recognizing autoinflammatory diseases. So just as an outline of what Seza and I are going to talk about, I'm going to talk quickly about general definition and classification of autoinflammatory diseases. I will then hand over to Seza, who will talk about autoinflammatory diseases, and we've divided them slightly arbitrarily between largely the recessive diseases and the diseases which mainly start in childhood. And then she will hand over to me largely to the dominant diseases and the diseases which more often we see in adults. And then between us, we will share the take-home messages. So starting with some general definitions. Autoinflammatory diseases are ancient disorders of innate immunity, which are caused by dysregulation of the innate immune system. And although they're very old, they were really characterized by work in the late 20th and early 20th century. And this was really led by Dan Kastner in the NIH, who was responsible for the initial definition of autoinflammatory diseases, which has later been refined, but it largely rests on the definition that he produced in 1999, following the finding of TRAPS, as autoinflammatory diseases as clinical disorders caused by defects or dysregulation of innate immunity, characterized by recurrent or continuous inflammation, with a lack of a primary pathogenic role for the adaptive immune system. And these have been incredibly informative experiments in nature, which have really led to understanding of the role of cytokine dysregulation in disease in general, the role of abnormal proteostasis, ER and mitochondrial stress, and autophagy. And although they aren't purely monogenic diseases, the majority of the ones which have been very informative and those first found have been monogenic. And the field of autoinflammation has exploded in line with the explosion in genetic diseases. And it's difficult to remember now that really DNA segregation of disease was a finding only in the 1970s, and that the ability now to talk routinely about doing broad genetic testing, even whole genome testing in individual rare patients is a finding of the 21st century, and that the ability to do broad genetic testing is very new. And in line with this, the number of genetic diseases that we know has expanded exponentially. This is shown in the table shown here, which comes from the patient group and shows the broadly recognized autoinflammatory diseases. You'll be very pleased to hear that we are not going to talk you through this entire poster, but we're going to highlight the diseases that are most commonly seen in practice, which are really the highest value to find. And part of the trick in clinically managing these diseases is to manage the balance between a high index of suspicion of what are high value but very rare diseases and over investigation. And I'll leave it to Seza to point out, particularly in children, where fever is a normal manifestation of a growing child, recognition of what is normality against what are rare and very significant diseases. This is a quick breakdown of analysis of the London Autoinflammatory Clinic, and we're a national referral centre of our activity in 2022. So we had 306 referrals of adult patients, so patients, most of whom were over 18, for what are supposed to be national level rare diseases. And about 60% of our patients are female. We had a few very small children referred, but almost 90% of our patients referred are over 18, and the ethnic background is about what you'd expect for a large Northern European country. So about 50% of our patients are Northern European, and then otherwise we have an ethnic mix reflecting what we have in Southeast England. Most of our patients come from rheumatology, but just under 20% from primary care and others from other specialists. And it's worth saying that just over 60% of the patients we see have no evidence of an autoinflammatory disease, and after workup in our clinic, we made another diagnosis. Of the 39.5% of patients who we saw who did have an autoinflammatory disease, I showed the breakdown of diagnoses in this graph. You can see that the majority of patients, even in the United Kingdom, in whom we make a diagnosis, have familial Mediterranean fever, followed by pericarditis, undifferentiated systemic inflammatory diseases, which I know you had a talk on previously, and then CAPS, and then a variety of other genetic diseases, including TRAPS, mevalonic kinase deficiency. I show in yellow the relatively small number of children who were diagnosed and have transitioned into adult care, and you can see the far larger number of patients who are still missed in childhood and in whom the diagnosis is made as adults. So it's worth saying that in these diseases, we still, in the UK, diagnose far more patients as adults than come having been picked up in childhood. And this is very important in terms of impact on growth and development in childhood. So how to diagnose these patients? The 2021 EULAR and American College of Rheumatology recommendations very clearly highlighted that genetic testing where available is the cornerstone of diagnosis and should be done where available. And the choice of genetic testing is Sanger sequencing if you're very sure that you know what the diagnosis is, but otherwise an NGS platform with broader genetic testing is probably better for picking up if you're not quite certain what the disease is. And that's very important because they can overlap. That said, genetic testing is not as easy as all that. This is work from one of my PhD students looking at the combined frequency of rare alleles across a panel which we've now slightly updated, but this is our routine panel that we perform looking for diseases, which is what we routinely look for in clinic for autoinflammatory diseases. And this makes the point that the combined frequency of rare variants exceeds 60% in healthy control individuals. So if you just do this panel and look for rare variants, 6 out of 10 individuals will have a rare variant. So you cannot rely on genetic diagnosis alone. There are tools that can help for this. The InFever's website is very helpful in telling you what is known about variants. So with known variants, you can get information about what is known about pathogenicity. But these are very, very variable genes, and many of these variants will not be previously known. And there is no data to guide you about whether this variant is going to be clinically significant or not. And so it's important to look at the patient and to use clinical metrics to decide whether or not you think the patient has disease. And there is data to help you with this. And clinical metrics have been looked at and published. And one very useful publication was led by Gattorno and used the Eurofever printer classification to look for the commonest of the genetic diseases and produce some clinical data to use clinical information to try to help guide what look like clinical diagnoses. We will come on to talk about this with the commonest diseases. And I'm now going to hand over to Seza to start with this in the diseases that tend to present earlier in childhood. So I will stop sharing now.
Okay, thank you, Helen. I'd like to thank the organizers for inviting me, and it's such a pleasure to do this with Helen. So can you see my screen?
Yes.
Okay, great. So we're going to switch from a very nice British English to my English now. So English as a second language. There are a number of classifications you can use for autoinflammatory diseases. I'll use this one to present you the most common ones in childhood. I'll start with inflammasomopathies, since these are the most common, and FMF is especially the most common disease over the world. So I will, in 10 minutes, I'll talk about those, and in the remaining 10 minutes, I'll finish up with the others. So inflammasomopathies are diseases that are characterized by the dysregulation of inflammasomes, In FMF, this is the pyridine inflammasome. In others, there are other inflammasomes. We'll give you the names. And we know that the mevalonate kinase deficiency also has its effect through the pyridine inflammasome, and we'll come back to that as well. And in the end, this inflammasome is responsible for an overactivation of caspase when it is dysregulated with these monogenic diseases, and thus the production of high levels of IL-1 beta that present to us the characteristic features. Now, the most common monogenic autoinflammatory disease over the world is FMF, the familial Mediterranean fever. And here, the mutations are in the MEF gene, Mediterranean fever, coding for pyrin. And it's a prototype of autoinflammatory disease, really. And it's like an experiment of nature on inflammation, where you see the characteristic recurrent attacks of fever and serositis, along with elevated acute phase reactants. Now, as Helen referred to, with Marco's leadership, we were able to suggest classification criteria for the common autoinflammatory diseases. And in FMF, as you can see, we talk about a confirmatory genotype, meaning since this is an autosomal recessive disease, if you have confirmed it, you have 2 pathogenic mutations. And on top of that, if you have just one of these, you can classify that child as FMF and you can start colchicine. But you see that we also have a subset saying non-confirmatory MEF genotype. So I'll refer to those now. Now, red flags in a patient. What should lead you to think about FMF? Fever and serositis at the same time, lasting less than 3 days. If it's more than 3 days, go and ask for a panel. High CRP, and you have to, of course, exclude other causes of fever in children, because these will present, 90% will present in childhood. The ancestry, it's a common disease in Eastern Mediterranean. It's not a rare disease. We think it's about 1 in 1,000 or 1 in 500, whereas in Europe, or North America, it's a rare disease. So it's less than 2 in 10,000. So how do we diagnose it once we suspect it? Well, as you can see, this is a recessive disease. So just like mevalonate kinase deficiency, or the 2 that I will talk about, you will need 2 pathogenic mutations to really confirm the diagnosis genetically. But there are problems. Now, one problem is that there are 54 likely pathogenic mutations, which are not always screened when you do a Sanger. Plus, there are 100 plus variants of unknown significance, which makes our life very hard. And so when you get back the result, you have to check the InFevers database or other genetic databases to see if you are dealing with a pathogenic mutation or a variant of unknown significance. Because if this is the case, you are kind of in the gray zone. So if you have 2 pathogenic mutations, that's fine. You can classify the child as FMF and you can start colchicine, but these are the gray areas. If you have just 1 pathogenic mutation, or if you have variants of unknown significance, this is the gray area where you have to check for the other autoinflammatory diseases and be sure that the patient does not have anything else before you start colchicine. So when the MEF genotype is back, you have to check the InFevers or other databases to see if this is a pathogenic mutation or a variant of unknown significance. If there is no mutation or it's inconclusive, you should ask for an autoinflammatory disease gene panel, but I must tell you that the yield is not high with these panels, and we can come back to this if we have questions. And if the panel is inconclusive as well, you should go to a whole exome sequencing or else. And then you can guide the analysis with your clinical judgment. And maybe it's a polygenic disease or a disease we do not know yet. If it's, again, inconclusive. Those are things you need to consider. So the geneticists and clinicians came together and we tried to summarize the approach for patients with monogenic autoinflammatory diseases. So if you're suspecting FMF, if the patient is meeting the classification criteria that I showed you, you can go for a Sanger. And you can do the same for if you are especially suspecting DADA2 or mevalonate kinase deficiency that I will talk to you about. But it's important to do a panel analysis if you're not sure of the phenotype, and you have to think about mosaicism. I think Helen is going to refer to this, and if not, you should maybe in the future whole exome sequencing will become cheaper, and maybe we'll start there. So colchicine is a primary treatment for FMF. I guess this audience already knows this, and we think that it prevents the secondary sequelae if used properly. And we have come up with a number of recommendations for how to manage these patients, and now we're in the process of developing an update of these recommendations, which I hope we will be able to present in 6 months or so. So let's leave FMF there and move to another very common, well, at least in Western Europe, a common autoinflammatory disease, monogenic autoinflammatory disease. And this is mevalonate kinase deficiency. Initially, you would think this is, you know, a metabolic disease, but it's not, because of these mutations in the mevalonate kinase gene, you have a dysregulation of the geranyl phosphatase, which activates the pathway again. We know that FMF also, the pyrene inflammasome also senses the external triggers through this Rho-GTPase system. And we now know that mevalonate kinase uses the same system to activate the pyrene inflammasome, and hence, again, with a lot of production of IL-1 beta. Now, it's a lot of patients have been described from the Netherlands and Western Europe, usually almost always presenting in very early childhood. As you can see, they can present with constitutional findings. Almost all of them have some lymph nodes, skin disease, two-thirds have GI symptoms. All of them have high acute phase reactants. So the red flags would be attacks of fever, not necessarily confined to 3 days. They might be a bit longer. And, you know, a lot of rash, you know, any kinds of rash. And this is seen in two-thirds of them, not all of them, not in all of the attacks. Abdominal pain, diarrhea, vomiting, they commonly have lymph nodes, maybe some splenomegaly. And we know that the attacks are triggered with vaccination, and that's a clue in the very young children because, you know, that's the time when we vaccinate them. The acute phase reactants are high, just as in FMF, they need to be high during the attacks. So this is the Eurofever criteria, classification criteria for mevalonate kinase deficiency. As you can see, again, we have a confirmatory or non-confirmatory solution. So if there is two, again, this is an autosomal recessive disease, 2 pathogenic mutations, and just one of these, either GI symptoms or lymph nodes, you can classify that child as mevalonate kinase deficiency and start treatment accordingly. But if you do not have a confirmatory genotype, then you would need 3 of 6. So age of onset younger than 1, GI symptoms, lymph nodes, after stomatitis, triggers, vaccinations mainly, and the rash. How do you treat these patients? Helen already referred to this. How to manage these patients have been summarized in this international consensus group, and you will treat the inflammasomopathies mainly, if not FMF, through inhibiting IL-1. But FMF, you start with colchicine if they're not resistant to colchicine. Now, there are other inflammasome-related diseases as well. For example, I think Helen will talk about CAPS, which is due to dysregulation of the NLRP3 inflammasome. And as you can see, there are others that are affecting the pyrene inflammasome. But I will have one slide on NLRC4 since it is so important for pediatricians, because This is characterized by recurrent macrophage activation syndrome. And you know, the pediatricians like this macrophage activation syndrome very much. We know that this disease also causes early onset inflammatory bowel disease. So it's always something you should consider when you have a patient with recurring macrophage activation syndrome. Before leaving the inflammasomopathies, I should say that there are new kids on the block. So recently there is a study going on to inhibit the inflammasome via back protein instead of using the IL-1 inhibitors. So we'll see how that one goes. So interferonopathies. Let's move to the second big group. So inflammasomopathies are dysregulation in the type 1 interferon pathway, so interferon alpha and beta mainly. And there are a number of abnormalities here. Some might affect the sensing of the nucleic acid, some might be causing an overactivation of STING, some might be causing proteasomal dysfunction, but in the end, you're having an excess of type 1 interferon response genes. So these are different than inflammasomopathies because inflammasomopathies, for example, are more characterized by the serositis, pleuritis, pericarditis, high CRP, and in the skin, it's usually a neutrophilic infiltration, whereas the interferonopathies, like the brain, they cause the basal ganglia calcification, they like the lung, they cause interstitial lung disease. CRP is not as elevated as we see in inflammasomopathies. They might have cytopenia, and the skin diseases, usually pancreatitis or lipodystrophy. With my fellow, we tried to come up with some clinical criteria that would make you think about these diseases. And when you think about them, you have to do an interferon score or you have to do a mutation analysis for these diseases. So skin, vasculopathy, lipodystrophy, joint manifestations, myositis, basal ganglia calcification, interstitial lung disease, and cytopenia should all lead you to think about these diseases. The most characteristic of them is SAVI. This is a really interesting disease. So it's a very early disease, starts in infancy, the eye comes from there. It's a vasculopathy and it's associated with STING. That's how the name is formed. And it's characterized by fever, somewhat increased acute phase reactants, and a very bad vasculopathy that causes tissue loss. Gangrene of fingers, septum perforation, and today someone was saying, dermatologist was saying that it looked like leprosy. In fact, it does. The lung has interstitial lung disease, and you might have fluctuating autoantibodies. So the vasculopathy is quite distinctive, and I'll come back to this because it's now considered one of the monogenic vasculitis, and this tissue damage can be very severe, such as this patient we have defined some years ago. The second group in interferonopathies is Aicardi-Gouttiere syndrome, although this more mainly affects neurologists. Sometimes they do have spillover lupus and they might have some vasculopathy as well. And the third group of interferonopathies is the proteasome-associated autoinflammatory syndromes. They are also called CANDLE because CANDLE kind of describes what the disease is. It's a chronic atypical neutrophilic dermatosis with lipodystrophy, as you can see in the scroll, and elevated fever. So this kind of tells you what the disease is. They can also have sometimes basal ganglia calcification. So the mutations are in PSMB8, and this is a subunit of proteasome, and mainly it's because of the accumulation of ubiquitinated proteins that result in intracellular stress. And then the third big group was the NFkB dysregulation, and there are the reloopathies here. I won't go into details with this because these are such rare diseases. We can come back if you have questions, but they are characterized by a variety of skin features and diverse features. For example, we know now that, for example, one of these NFkB disorders, HA20, haploinsufficiency of A20, can also lead to early lupus and can also be a predisposer for malignancy. Otolinopenia, again, it's a very strange disease with very marked skin disease and sometimes vasculopathy. And of course, this time you will treat these patients with anti-TNF instead of anti-interferon or anti-IL-1 drugs. The last group I wanted to talk about, I'll leave the protein folding defects to Helen. So the last group I want to talk about is DADA2, because DADA2 has been a real game changer in pediatrics. Now, SAVI and DADA2 seem to be monogenic autoinflammatory diseases that cause monogenic vasculitis. So I already talked about SAVI. Let me touch upon DADA2, and it mimics polyarteritis nodosa. It's interesting because it has shown us that with just one mutation in a rare mutation in a gene can cause the same disease as the polygenic counterpart of polyarteritis nodosa. So it does resemble polyarteritis nodosa. It's characterized by loss of function mutations in the EDA2 gene, and it also causes early stroke. The pathogenesis is mainly due to the macrophage polarization and altered endothelial cell integrity. And you cannot distinguish the angio findings or biopsy from polyarteritis nodosa. And it can also cause some immune deficiency and sometimes cytopenia as well, which is different than what you see in polyarteritis nodosa. When you suspect it, you have to do either the enzyme level or you have to test for the gene mutations. And we have problems here. What are we going to do with one mutation? Is the enzyme level enough? Test all pan siblings, et cetera, et cetera. So these are the problems we still have to contemplate among pediatric rheumatologists. I'll skip these because I'm kind of killed my time, so that we can have time for your questions. So from my part, from the pediatric part, I think the take-home messages are that you have to suspect the monogenic cause for very early onset rheumatic diseases or those with a family history or consanguineous marriage. And I must say that when you think is a rare manifestation of a common disease, is probably the frequent manifestation of a rare disease you do not know yet. So with that, I'll hand over to Helen. And before I do that, I would like to invite everyone to the PRESS 2024 meeting that will be held in September in Gothenburg. Thank you, and I look forward for your questions. I'll stop sharing and hand over to Helen. Did I stop?
Thank you. Can you see my screen now?
Not yet, but
did I succeed in stop sharing?
yes, now we see Helen's slides. Okay.
Oh, fantastic.
Perfect.
Thank you very much, Seza. So I'm going to move on to the dominant diseases now, which we quite frequently see presenting in adulthood, although they've often had disease in childhood which either didn't present or was misdiagnosed. And the majority of these patients will then present having had 5 previous diagnoses before the monogenetic diagnosis is made, often in adulthood and not infrequently when they have already developed complications. So the first of the diseases I'm going to talk about is TRAPS, the TNF receptor-associated periodic fever syndrome. This is a dominant disease, although like all of these diseases, it displays variable penetrance, and only about 60% of individuals will describe a family history, which is suggestive. It was first described in the United Kingdom in 1982 as familial Hibernian fever, which was a bad joke. Hibernia is an ancient term for Ireland, and the first families had Irish ancestry, and this was meant to reflect familial Mediterranean fever. The genetic cause was identified by Michael McDermott when he was working in Dan Kastner's lab in 1999, and it was found to be due to mutations in the TNF receptor superfamily 1A. And this is a rare disease with an estimated prevalence now of probably about 2 per million. And as far as we know, it affects all world populations. And the difference in prevalence in different populations is almost certainly ascertainment bias, reflecting the ability to recognize autoinflammatory disease against a background of infectious disease, and also the availability of genetic testing. And the largest series of patients came from a Eurofever's Eurotraps project, which was funded by the European Union in 2011. And this produced good baseline data on 199 patients. It's worth saying that there are some very common polymorphisms in this gene, which causes diagnostic confusion. And some of these are very difficult to interpret, particularly the polymorphism that was initially called R92Q, but with which relabeling of the promoter is now called R121Q, and which is present in about 2% of the healthy population, and whose significance remains very contentious to this day. But if we just focus on disease which is associated with what we think as proper pathogenic mutations, this is still a pretty pleomorphic disease. One reason that it's so variable is that the mutations tend to be individual or family specific, and at least 58% of the mutations are really very family specific. So unlike familial Mediterranean fever or indeed CAPS, most mutations will be unique to the kindred in which they're found. The majority of mutations are in the extracellular portion of the protein, and there's often a lot of mutations in the cysteine bonds. There was some interest in whether this is because the cysteine bonds are particularly important. I don't think they are. I think it's just because there are an awful lot of cysteine bonds in the extracellular portion. And we now know, I wasn't going to show a pathophysiology slide here because this is about recognition, that there is no extracellular signaling of the TNF receptor in TRAPS. This is a protein misfolding disease. The abnormal protein is trapped in the endoplasmic reticulum and causes ER stress. So there is no TNF signaling involved here at all. So my view is always that the disproportionate amount of cysteine here just reflects the fact that this is a very, very cysteine-rich protein. The manifestations of this disease are, on the whole, around musculoskeletal pain, fever, and non-peritonitic abdominal pain. Rash is common, eye involvement is common. And these manifestations can vary from attack to attack, and they change a bit through age as well. So TRAPS can change a bit over time. But the disease is very similar between children and adults. And shown here is a pretty typical serpinaceous rash in one of my adult patients and the sort of eye involvement that we see. And when we look in a cartoon, about 90% of patients will describe fever with attacks. Rash is seen in more than 60% of attacks, and doughy abdominal pain is very common, as is muscle and joint involvement. And characteristically, attacks can be pretty long, with a third of patients having very prolonged attacks, but short-lived attacks can occur. And as patients age, about a third of patients will go on to have a much more chronic disease course. So in children, attacks can be short-lived with prolonged intervals in between of being well, but about a third of patients as they get older will run into having really very persistent disease activity almost all the time, with episodes when their disease seems worse to them, but they never quite normalize. Generally speaking, attacks are unprovoked, but they can be precipitated, as is often the case in autoinflammatory disease, by increased physical activity, emotional stress, or physical trauma. And I think the major thing that will induce an attack in adults is a budget holiday. So going through Ryanair, EasyJet, trying to get your family on holiday will usually start an attack at the beginning of a holiday very reliably. There are no genotype-phenotype correlations, so there isn't any particularly severe mutation that we identify. And consensus criteria from EULAR-ACR has suggested that the following considerations should prompt a diagnostic workup for TRAPS: long-lasting fever episodes, migratory rash, typically going down a limb with underlying pain worst underneath the rash, periorbital edema, particularly in children, myalgia, and a family history of similar symptoms. The consensus classification criteria published in 1999 from 1919 from EULAR Printo came up with really three quite useful ways of looking at this. First of all is in the presence of a confirmatory genotype, and you only need one mutation because this is dominant disease, at least one of fever episodes lasting more than 7 days, myalgia, a migratory rash, periorbital edema, or affected relatives in the presence of evidence of systemic inflammation, so with constitutional symptoms in a raised CRP or SAA, or in the presence of variants of unknown significance, at least 2 of those features. If genetic testing is not available and you're doing this on clinical features alone, A point score was developed, and you needed 5 or more points, with points attributed to fever lasting a variable number of days, migratory rash, periorbital edema, myalgia and a family history, and also with recognition that some features were not suggestive of TRAPS, particularly aphthous stomatitis and pharyngotonsillitis, which are really not particularly significant, not particularly suggestive of TRAPS. And these scores were validated in what, as far as the investigators were concerned, quite an onerous and rigorous process. When it comes to treatment of TRAPS, there are a number of treatment options. It's worth saying that 10 to 15% of patients with TRAPS can be managed with symptomatic treatment alone. And in these patients, as with all autoinflammatory diseases, a mixture of non-steroidal anti-inflammatory analgesia and paracetamol is often the best. Short-lived attacks where the patients are clearly well in between, with normalization of their acute phase response markers, can be handled with corticosteroids, and most attacks of TRAPS can be aborted by a dose of corticosteroids of between 0.5 and 1 milligram per kilogram, and we tend to find that they will abort with about a 5-day course. There is no evidence to support using anything except corticosteroids to abort an attack, and we would, in our practice, never use anything except intermittent corticosteroids. The evidence for long-term treatment for biologics really only supports anti-IL-1 agents, and response to anti-IL-1 agents is extremely good, to the point where if the patient does not respond to IL-1 inhibition, the diagnosis of TRAPS should be reconsidered. So failure to respond to an anti-IL-1 agent would strongly suggest that the patient does not have TRAPS. I'll come on to this again in a moment. The response to anti-IL-1 agents is so good across such a broad variety of diseases that response to anti-IL-1 cannot be used clinically, in my view, to diagnose TRAPS, but failure to respond should make you reconsider the diagnosis. Moving on to the next of the diseases, CAPS, the cryopyrin-associated periodic fever syndrome, is a disease that was first recognized as a single disease following recognition of the gene causing this in 2002. And this was first published in 2001 by Hal Hoffman, and we found the gene a couple of weeks later for mid-spectrum disease, Muckle-Wells. The disease has actually been recognized since the 1940s, causing familial cold urticaria in the United States, and the severe end of this disease was recognized by Anne-Marie Prieur as SINCA, NOMID, and what it's called NOMID in the States from the 1980s. And it was the finding of the gene that meant this was recognized as being a single disease severity spectrum. This is, in a sense, the paradigm of autoinflammatory disease, with the recognition that mutations in NLRP3 cause constitutive overactivation of the IL-1 inflammasome, and that this disease is driven by overproduction of interleukin-1. CAPS has a remarkably uniform phenotype across the disease severity spectrum. So at the mildest end of the spectrum, symptoms tend to be precipitated by exposure to cold or damp environment, with an urticarial rash, arthralgia, and a red eye. At the most severe end of the spectrum with synconomid, there is severe damage from chronic progressive meningitis with sensorineural deafness, visual loss due to eye inflammation at all levels of the eye from anterior to posterior, and a progressive destructive arthritis. Mid-spectrum disease, which is actually the commonest that we see, tends to cause disease with the circadian rhythm worse towards the end of the day, with urticarial rash, fever, red eye, significant myalgia, and actually a meningitic headache being extremely common. Most individuals will present at birth with an urticarial rash and fever, which may be confused with neonatal sepsis, but many individuals will then not present until adult life, having essentially normalized their symptoms. Mutations commonly occur in exon 3 of NLRP3, but can occur elsewhere, particularly in NOMID SINCA. And in mid-spectrum disease, autosomal dominant inheritance is common, but again, only about 60% of our patients will have a family history. Unlike TRAPS, symptoms are very consistent. So this was a publication from our center looking at symptoms across the disease spectrum. This was in about 30 patients. What I just want you to see is just how very consistent the symptoms are across the whole patient group, with between 90 and 100% of patients reporting the same symptoms. So these are widespread day-to-day symptoms of urticarial rash shown here. It does look as if it's very damaging and itchy. Classically, the patients don't itch. They have flu-like symptoms in up to 90% of patients. Anterior eye inflammation is seen in 95% of patients. There is an anemia which looks like a combination of anemia of chronic disease and iron deficiency, because IL-1 downregulates hepcidin, so they are genuinely a little bit short of iron. And meningitic headaches are seen in about 64% of patients. This predisposes them to develop migraine later in life, and chronic fatigue is seen in almost all patients, which is IL-1 driven. This is associated with long-term damage. Through childhood, 55% of patients will develop a stepwise onset of sensorineural deafness, associated with, in almost all cases, normal acquisition of language, because they don't start losing their hearing until after they've acquired language. Bone and joint deformities are seen in up to 20% of patients. This is often relatively subtle, but clubbing is seen in at least 1 in 5 patients. And there are risks of more severe damage, with visual loss occurring in up to 10% of patients. And before the advent of effective treatment, early death due to renal failure from AA amyloidosis was seen in more than a quarter of patients. This here is an SAP scan showing amyloid in the spleen, the kidneys, and the adrenal glands. This is the typical appearance of amyloid on Congo red staining. CAPS is the only disease in which there are validated diagnostic criteria. These were produced in 2017 in a consensus group, and the diagnostic criteria here were in the presence of raised inflammatory markers, which had to be seen, 2 out of 6 of typical CAPS symptoms of an urticaria like rash, cold or stress-induced episodes, sensorineural hearing loss, arthralgia, arthritis or myalgia, evidence of chronic aseptic meningitis, and skeletal abnormalities were enough to make a diagnosis and to differentiate from alternative diagnoses, including Schnitzler syndrome. The classification criteria again usefully divide this between in the presence of a confirmatory genotype, when the requirement is at least 1 of the characteristic urticarial type rash, evidence of a red eye with involvement which can be conjunctivitis, episcleritis, or uveitis, or evidence of sensorineural hearing loss, or in the presence of a non-confirmatory genetic variant, at least 2 of them. When genetic testing is not a presence, again, at least 2 variants are required, at least 2 of rash, cold or stress-induced symptoms, sensorineural hearing loss, chronic aseptic meningitis, and skeletal abnormalities required, in combination with all of these, with evidence of inflammation. And these were very, very sensitive in the presence of genetics, and reasonably sensitive and accurate in the absence of genetic testing. These are very, very high value diagnoses because treatment transforms outcome. And as with TRAPS, the treatment is IL-1 blockade, no other treatment is effective. And failure to respond to IL-1 blockade should make you question the diagnosis, although it has to be said that in the severity spectrum of CAPS, the dose of IL-1 blockade required is higher for more severe disease than lower disease. In adults, there is a recognized phenomenon of mosaic CAPS. So of the adults who we see presenting to our center, 9% of the patients who present to us as adults genuinely have a late onset presentation of CAPS. They did not have disease in childhood. And in these patients, they have somatic mosaicism accounting for their disease. And in these patients, onset of symptoms is at 50. Their disease characteristics are the same as patients with germline mutations, except for the late onset. They tend to have the same level of damage in terms of hearing loss, but they have no growth retardation. They have a higher risk of AA amyloidosis, we think probably because the diagnosis was missed for longer. They also respond dramatically to IL-1 blockade. This is important in terms of genetic testing, because if you do genetic testing with whole genome or whole exome sequencing, with present technology and the amount of DNA available, there is a trade-off in terms of the breadth of genetic testing available to you and the depth of genetic testing available to you. And very broad genetic testing means that you don't actually manage to test that many separate cells, and you can miss low-level somatic mosaicism. So one reason that when we are screening adults that we prefer to do genuine panels and only test a small number of genes rather than doing whole exome and only reading a panel is that the depth of testing and the number of reads we do enables us to pick up low-level mosaicism, and that is very, very relevant in picking up adult acquired mosaicism responsible for acquired disease. The other disease that we worry about in adults is Schnitzler syndrome, which is a mimic of adult acquired CAPS. This is a disease that was described by the French dermatologist Liliane Schnitzler in 1972. It has diagnostic criteria again validated, and this requires a chronic urticarial rash, which like CAPS on diagnosis is a neutrophil dermatosis in association with a monoclonal gammopathy. And in 85% of cases, this is an IgM. In 10% of cases, it's an IgG. And again, in 85% of cases, the light chains are kappa, not lambda. Minor criteria in association with this are a history of recurrent fever, evidence of bone remodeling, and an elevated CRP. And this requires 2 obligate criteria and 2 minor criteria if an IgM or 3 if an IgG. This is a disease where we think the underlying driver is the monoclonal protein, but it's not clear how this results in a phenotype which otherwise very closely resembles CAPS. Because it's driven by a bone marrow dyscrasia, it's a bit commoner in men than women, because bone marrow dyscrasias are always a bit commoner in men than in women. Median age at onset is early 50s, and there can be a degree of evidence of bone marrow involvement with either Waldenstroms or LPL, with hepatosplenomegaly, and there is a risk of progression to true malignancy requiring chemotherapy, but this is fairly small, with only a small proportion of patients ever progressing to genuinely needing chemotherapy. Bone marrow, as I said, shows a low-grade IgM paraprotein and a neutrophilic infiltrate on biopsy. This is a rare condition with fewer than 300 patients reported worldwide. I suspect this is an underreport because we have about 50 patients in the United Kingdom. And all of these patients respond dramatically to IL-1 blockade. Failure to respond to IL-1 blockade, as with all of these diagnoses, should make you reconsider the diagnosis. Response is instantaneous and complete. Patients on IL-1 blockade, at the moment in our series, none of them have progressed to requiring chemotherapy. We will wait to see whether that changes, but certainly treatment doesn't seem to alter in an adverse fashion prognosis. And finally, the last of the diseases I want to talk about is the most common described and is the last acquired disease that has been recognized in adults and is another example of somatic mosaicism. And this is Vexas, which is vacuole's E1 enzyme X-linked autoinflammatory somatic syndrome. And this is a syndrome which is due to acquired somatic mutations in UBA1, the primary ubiquitination enzyme in man. This was recognized in October 2020 and is a fascinating disease with a very, very diverse presentation, which can present to rheumatologists with a phenotype which either looks like relapsing polychondritis or vasculitis, to hematologists with myelodysplasia or MGUS-like pattern, or to dermatologists with sweet syndrome, erythema nodosum, or diffuse rashes, or to autoinflammatory doctors with recurrent fevers and something which looks a little bit like Schnitzler syndrome. It predominantly affects men because UBA1 is encoded on the X chromosome, and it causes a late onset refractory inflammatory syndrome with a poor prognosis. It appears to be a form of an interferonopathy because it looks like failure of ubiquitination results in ER stress and in upregulation of a number of pathways involved in the interferon pathways, and these patients do badly in a variety of fashions. The clinical manifestations, as I've said, are very variable, and it may well be that our choice of treatment and our prognosis does depend a bit on which of the clinical manifestations predominate and which specialties these patients present to. And at the moment, this is a disease with a fairly poor prognosis where we have more questions than answers. The largest, at the moment, there are really only a handful of cases available to be described, but we think it is majorly underdiagnosed and that this may well be relatively common compared to other autoinflammatory diseases. The vast majority of cases are male, but women are recognized either due to undiagnosed monosomy X or potentially due to inactivation of the X syndrome. It's a late onset disease with median age at presentation between 55 and 65. Screening has suggested that it may be commoner than we think, particularly in relapsing polychondritis, but possibly also in refractory vasculitis patients. Red flags, particularly in male patients, are an MCV of over 100, platelets of under 200, and evidence of polychondritis sparing the airways but presenting the nose to the nose and ears. The best series of clinical features comes from Sophie-Georgienne Laval, who described a series of 111 French patients and described symptoms including rash, fever, weight loss, myelodysplasia, lung involvement, a tendency to venous thrombosis, chondritis, and also peripheral neuropathy and cardiac involvement. This is summarized in quite a nice review paper from Vitali et al., which was published in January of last year, and which summarizes the different symptoms here. And as I've said, one thing which is not quite clear to us at the moment is whether patients presenting to different specialties will turn out to have somewhat different prognoses. At present, the prognosis seems fairly grim. Let me see if I can move on. Laboratory features at the moment are most patients will have macrocytosis, be anemic with some evidence of dysplasia and systemic inflammation. The majority of the somatic mutations affect methionine 41, but other mutations are recognized, including at splice sites, and additional MDS mutations may well worsen the phenotype and are present in up to 22% of patients. Survival by the common variants does seem a bit different. There is an impression that the higher the somatic mutation percentage, the worse survival will be. So as you acquire more mutations, this has a worse impact on survival. And also that the valine mutation at position 41 has a worse impact on survival than the leucine mutation. There is classic vacuolation seen here on bone marrow, which is a good diagnostic clue if you're doing a bone marrow looking for myelodysplasia. Prognosis appears to be poor. At the moment, the cohorts are not that old and they're maturing, so we'll see. But the initial NIH reported 40% survival at publication. A Dutch series at a median follow-up of 4 years reports only 50% survival. And the very large French series at a median follow-up of 3 years reported that almost 16% of their patients had died, largely of infection. And we too had a very poor outcome, particularly with the COVID. Poor prognostic factors include medial lymphadenopathy, gut involvement and lung infiltrates, and there's a suggestion that patients with chondritis, particularly affecting the ear, do a little bit better. Patients with bad enough myelofibrosis to be transfusion dependent, unsurprisingly, do very badly. At the moment, we are uncertain how to treat these patients. It's an evolving picture. Most patients have progressed through a number of lines of treatment. And treatment at the moment is a combination of support for the bone marrow, so with the erythropoietin and transfusions as required, steroids, which seem to be absolutely necessary, but most patients become steroid dependent and Cushingoid, treatment aimed at rash, but that is purely symptomatic. Conventional DMARDs seem to have failed. Most centers are trying biologic targeted treatment, and there is modest benefit reported for IL-6 inhibition, IL-1 inhibition, but terrible problems with rash associated with anakinra, and some reports for benefits with anti-TNF agents. There's been some interest in Janus kinase inhibitors, with some suggestion that ruxolitinib may be preferable to other agents. azacitidine, which is a licensed agent and a pyridine nucleoside inhibitor that impairs DNA methylation, may be useful, not just in treatment of myelodysplasia, but also suppressing inflammation. And there is interest in allogeneic transplantation. This is a high-risk procedure, and although it may be curative, the risk of treatment-related mortality so far has been really quite considerable, and patient selection appears key. So in adult autoinflammatory diseases, it has to be said that these are essentially the poster child for reverse translational medicine of the last 25 years. In autoinflammatory diseases, there has been an astonishing coming together of advances in genetic and molecular biology, clearly defined patient cohorts and pharmacology, which has meant there's been an astonishingly productive period in genetic diagnosis, characterization of patients, and new therapies. It means in rare diseases, for a number of these, we actually have clearly characterized, licensed, and available treatments which we know are safe. Currently at the moment, largely focused around agents which block IL-1. These have been incredibly useful and have, for many of us, defined patient cohorts and the ability to treat, and have transformed these diseases into extremely high-value diagnoses, which rely on a high index of clinical suspicion. The importance of diagnosis, the untreated disease carries a very high risk of severe morbidity, long-term damage, and early death, but treatment can reverse all of these. So we have very high expectations of excellent outcome in well-treated patients in the 21st century. But these are high-cost treatments which need to come from specialist centres and absolutely rely on early, accurate diagnosis. And I'd just like to stop there and say thank you very much for being asked to talk.
Excellent. Really, really excellent. Thank you very much. That was really fantastic job from Professor Özem and Professor Lachmann. We ask to the people to write some possible question. We have, I think, at least 5 minutes for some question. I will start, if Sefi give me the chance, with a question from Alexander below that I would like to congratulate because he's the organizer of this webinar, and I think it's a great success because there are more than 140 participants. So congratulations, Alexander. His question is to you. Fantastic talk and great. It says, have you an idea about the threshold of a mosaicism that is sufficient to induce autoinflammatory disease? And do you anticipate that is the same for all autoinflammatory disease, NLRP3, SAVI, Vexas? Difficult question, as usual, from Alexander, who wants to reply.
Well, with mosaicism, I think Helen should reply.
Oh, I don't know.
So it's easy.
That's why I put it to you.
I think all dominant diseases we will see mosaicism. I think working out the impact of mosaicism we will have to see. But I think the no thought answer is that for every dominant disease there will be mosaic cases.
May I ask you to both of you, which is your strategy to use genetic in your daily life? Of course, because maybe there is a different perspective, the need to find out mosaicism in adulthood, and I would like to have maybe also the viewpoint from Turkish expert, in which of course FMF is very, very much. So can you comment on that? Because it's quite important.
So, yeah, thank you. We first start with a MEF mutation analysis. I mean, if the patient does not have a very outstanding feature, such as skin disease or something else that is alarming, we would do first mutation analysis of the MEF gene for a patient presenting with recurrent fevers. If we do not find the common pathogenic mutations, we move on to do a panel. And in this panel, we do a full sequence of the MEF gene as well. If still we cannot find anything, and there are features suggestive of CAPS or TRAPS, we ask for specifically for mosaicism to be analyzed. And if not, we stop there. I think our yield is around, with the panel and doing all of these, I think our yield is around 15–20%. So like in a good majority, we're not able to pinpoint the disease, and maybe they have polygenic disease or PFAPA. We call them unclassified autoinflammatory disease.
Helen?
Yeah, I think it's very difficult. And the difficulty is around the bioinformatics. So it comes down, I think, as with all things, to how clear you are on your question. So genetics is a very difficult tool, and the more you do it, the harder the tool I find it. So if you are very clear on the question you are asking, is it FMF or not, it is best to do a single gene, because then you can answer the question. If you are asking, is it an autoinflammatory disease, the panel will give you a clearer answer. And I speak as somebody who has to report a panel for most of a country and actually produce a report that somebody can read. If you have a very sick child and you want to know what the problem is, you want to do whole genome, but who is going to report that? How good is your bioinformatics? And what do you communicate to the family? And can you do that for 2,000 people in a month? So I think you have to have a pyramid of, are you doing routine diagnostics? Are you trying to channel people into a therapeutic service? Are you investigating a small number of very sick individuals where you may not come up with an answer, but you then have to have a plan for how you are going to communicate with the patient and their family, the uncertainty, and that you've done a test to which the answer you give at the moment is contingent and is going to keep changing because you've done the sequencing, but the interpretation will change every time a new gene comes out.
Yeah, sure.
I agree that bioinformatics is our bottleneck at the moment. I mean, less is getting cheaper, but that's our bottleneck. I mean, in Eastern Mediterranean, of course, it's different than in Europe because, you know, we have thousands of FMF patients in Turkey, Lebanon, Israel, Armenia. So it's different for Eastern Mediterranean and Cyprus as well.
Okay. Sefi, do you want to go on with some questions?
Yes.
I have to leave in 2 minutes. I'm sorry.
Okay, the last two minutes of question. And then we go.
We have another question by Ecterini for Helen. Is it possible to have Schnitzler related to monoclonal IgE?
I've never seen it. I think with a monoclonal IgE, I would be very concerned that we're missing an IgE related disease. So I would be looking for monoclonal IgE associated diseases first.
Okay, thank you. And Seza, before you go, Stevens asked, do you still use functional assays to diagnose mevalonate kinase deficiency?
No, we use the panel.
The panel.
For mevalonate kinase deficiency.
Even if sometimes if you have an heterozygous patient, maybe it could help maybe to find out the deletion and to search for the deletion if the mevalonate kinase the mevalonate in the urine is increased. So sometimes can be useful. Good.
Yeah.
Okay, fantastic. I think that we really have to thank Seza and Helen for the fantastic presentation. Really, in 1 hour, we have a fantastic overview on all autoinflammatory diseases and how to approach from the diagnostic point of view. I would like to ask all the organizer, Alexander below, and the ERN-RITA secretary, that as usual was very, very useful, and also my friends and co-moderator Sefi, Uziel, for the great moderation. Thank you very much.
Thank you very much. Thank you, chairs. Thank you very much. Thank
Thank
you.
you.
See you very soon.
Bye.
Thank you. Bye bye.